all the memory of rainy afternoons, swingy Harlem tunes, motor trips and burning lips and burning toast and prunes. How lovely it was. Thanks for the memory of candlelight and wine, castles on the Rhine, the personal and moments on the Hudson River line.
Just the last name of the day of the birth.
How lovely it was. Many's the time that we feasted, and many
Vulture.
lasted.
Just trying to do my part.
Well, it was swell while it lasted. We did have
Well, good afternoon. Most of you know me because I've given this talk before, but if you don't, I'm Nick Musi. I'm the director of the Geriatric Research and Education Center, and I'm also in the faculty here as an endocrinologist and diabetes specialist. You can't hear me?
Hear you too well.
Is that better?
Yes.
Okay. So I'm the director of the Geriatric Research and Education Center here in the VA, and I'm also staff and endocrinologist and a diabetes specialist. And I'm very interested in trying to find out why our elderly patients have such a high risk of developing diabetes. So many of you have noticed that, in your clinics, that when you have patients that are 30 or 40 years old and they have type 2 diabetes, most often they'll be overweight. But you will also notice that you have patients that may be 60, 70, or 80 with type 2 diabetes, and many of those patients are not obese. And you may wonder, why is this older person diabetic if they're not obese? And that is because aging alone, independently of obesity, is a very important risk factor for developing type 2 diabetes. And we're being very interested in trying to find out what is the mechanism for that phenomenon. So I'm going to talk briefly about the epidemiology of diabetes in the elderly and some basic concepts about the pathophysiology. Why does diabetes happen so frequently in older patients? And then just some practical discussions about how to manage diabetes in the elderly. What is different compared to management in younger people or in middle-aged people? So this figure, it's essentially it shows the estimates of cases of diabetes in the world. And you can see it has been increasing slowly, but suddenly from 2000 to 2010, there's a huge jump. And the new data, which is not here, then shows that diabetes is increasing at an even faster rate. And this is worldwide, not only in developed countries, but also in third world countries. So obviously this is very concerning because diabetes is the most frequent cause of blindness and kidney failure and amputations in most countries, and also major risk factor for cardiovascular disease. So it's imperative that we understand why that's happening so we can prevent it. So one of the obvious reasons for such a rapid increase in cases of diabetes is that as people are being less mobile, less physically active, and eating more calories, that excess energy intake leads to obesity. So obesity is a key driver for type 2 diabetes. But the other is what alluded before, that as people are, that aging independently of obesity is an important risk factor. So as treatments, both preventative strategies and treatments for main causes of mortality, including infection, cancer, even cardiovascular death rates are decreasing, so people are living longer. So aging itself, combined with obesity, is pushing this problem of type 2 diabetes. Most of the cases that you're seeing here are driven by type 2 diabetes, and I will talk more about that. This is a figure that shows the prevalence of type 2 diabetes that is diagnosed, meaning that the patient and the physician know that the person has type 2 diabetes. Also, cases of undiagnosed type 2 diabetes, it is generally estimated that for every case of diabetes that is diagnosed, there's another case that has not been diagnosed yet. And lastly, there's also data regarding the number of people, or the percentage of people with a condition or a state called impaired glucose tolerance, also called glucose intolerance or prediabetes. And these estimates are based on glucose tolerance tests. So the glucose tolerance test, most of you know, but for those who don't, it's a test in which a standard dose of what glucose is given orally, 75 grams, and then glucose concentrations are measured for 2 hours. And if in the 2-hour time point it's up to 139, it's considered normal. If it reaches 140 up to 199, it's considered prediabetes or impaired glucose tolerance, and if it reaches 200 or above, it's called diabetes. And it's called prediabetes if someone has impaired glucose tolerance, because the risk of that person becoming diabetic, crossing the limit to diabetes over the next 5 years is pretty high, nearly 50%. But the key thing what I want to show you here is that all these states of abnormal glucose metabolism, diabetes and prediabetes, increase with aging. So if a person is 65 or higher, it has a 50% chance of being diabetic. In other words, to put it, 1 in every 2 people who are 65 and older have diabetes or prediabetes. And it's very likely this is going to get worse. So obviously it's very concerning. And I'm sure that in your clinics and in your practice, you notice that many of your older patients have diabetes. So why diabetes increases so much with age? So in order to try to understand this, I'll go through some basic concepts of physiology of diabetes. So what you see there is a stomach and in the small bowel. So in normal circumstances, when we eat a meal, and the substrates, glucose and other nutrients get absorbed and into our system, and as the blood glucose starts to rise, the pancreas, which is right in the middle, it secretes insulin, and it secretes it for many reasons, but one of them is to maintain glucose levels within a normal range. Obviously, glucose is very important for all the cells in our body, but very high levels of glucose is very toxic to the cells, particularly the blood vessels and neurons in our eyes, the kidney cells, the nerves and capillaries in our legs. High glucose levels is very toxic. So that's why it's so important that our body keeps glucose levels tightly regulated. And it does so through different mechanisms, but the most prominent is release of insulin from the pancreas, right? So as you have a meal and glucose levels start to rise, the pancreas will release insulin to keep it, to prevent it from increasing very much. And it does so by affecting different tissues. One of them that you see there, it's the skeletal muscle. So the insulin will make the muscle to start taking up the glucose that is in our blood. The skeletal muscle is the main tissue that takes up the glucose, and it can take a lot of it. And it'll store it in the form of glycogen, but it will also burn it, will oxidize it. So obviously that's very important to maintain normal glucose levels, because the muscle will take it up from the blood. The other is important effect of insulin is to suppress the production of glucose by the liver, which is shown there. So in normal circumstances, the glucose is constantly taking up different nutrients and making glucose, right, from a process called gluconeogenesis. And that is highly regulated by insulin. And if in the absence of insulin, the liver takes up huge amounts of nutrients and makes very large amounts of glucose. So the liver, the insulin, what it does, it suppresses the liver and makes it prevents it from making too much glucose. And lastly, you see there also adipose tissue. So insulin has an important effect in the adipose tissue to prevent release of fatty acids. So collectively, those are the most prominent effects of insulin to maintain glucose levels in normal circumstances. But something that happens with obesity and type 2 diabetes, probably the first thing that happens is that even if before a person becomes diabetic, is that these tissues become insulin resistant. There are different reasons for this, but the typical scenario is a person who was lean and active when they were young, and then for different reasons they are not able to be physically active, and they are sedentary and they're eating more calories, they're starting gaining weight. So gaining weight and being sedentary makes these tissues very resistant to insulin. So how is that manifested? The muscle cannot take up the same amount of glucose. The insulin is not as effective in preventing excessive production of glucose by the liver, and also the adipose tissue release is breaking up too much fat. Now, the beta cells are pretty smart, unquote, and they can detect when a person is becoming insulin resistant, and what they will do is they will make the beta cells in the pancreas, they will secrete more insulin. And they will do that to overcome the insulin resistance. So they'll say, okay, this person is not exercising, is gaining weight, and the insulin I'm making is not enough, I'll make twofold, or threefold, or even tenfold. And eventually, they make sufficient insulin to overcome the insulin resistant, and that person may be protected from becoming diabetic. They likely are insulin resistant, but not necessarily diabetic. And about 80% of people who are insulin resistant, luckily for them, their body, their pancreas, can keep up for the rest of their life, making massive amounts of insulin. But unfortunately, about 20% of the people that are insulin resistant, eventually those beta cells cannot keep up and they will start failing. And when they start failing, not able to produce sufficient insulin, that's when the high glucose becomes evident and they are overly diabetic. So that is a typical pathophysiology of type 2 diabetes. In type 1 diabetes, which can also happen in type 1 in elderly patients, the problem is very different, and I'm not going to discuss it today other than to say that the nature of type 1 diabetes is an autoimmune problem in which the immune system attacks the beta cells in the pancreas and destroys them. And the cause for that is not clear. There's some genetic predisposition and perhaps some environmental toxins and viruses that may be related to that. But in general, the pathophysiology is very different. In type 1 diabetes, very little insulin is produced, whether it's in type 2 diabetes, insulin is being produced, but not sufficient to protect the person from becoming diabetic. So one key question that people that have been doing research in this area is what is the main problem that happens with aging? Is it that the beta cells are not working as we get older, or is it that our tissues become insulin resistant? So I will discuss that. We have some data I can show you. So this is from one of our studies to test whether aging per se, independent of obesity, can affect the capacity of the beta cells to produce insulin. So we enrolled 3 groups of subjects. Subjects that were young and healthy, so these are non-diabetic. We just want to see the effect of aging in a normal beta cell function. So we have young people who are lean and white. Then we also enrolled older subjects that were also lean, they were healthy, they were matched. Also for physical activity, the only difference is that they were older. The mean age of the older group was 75, the younger group was 25. And the older group were divided in either if they have normal glucose tolerance or impaired glucose tolerance based on the glucose tolerance test, which is shown to your left panel. So that is a glucose tolerance test, and we put a catheter and measure glucose and insulin over a period of 2 hours. Then we follow glucose and see whether the beta cells can produce, or how much insulin they produce in response to the glucose rising. So let's look at the young people first, which is in white. So you can see that the person takes the glucose drink, and glucose starts going up in the blood. And then look to your right, which is the insulin level in the blood. As you can see, within 15 to 30 minutes, there is a big boost of insulin being produced and released, primarily released into the circulation in these young people. And it peaks for about 45 minutes. There's a very large amount of insulin being produced. And as you can see, if you go look back to on the left panel, 45-minute time point, glucose levels start decreasing, because that insulin that the beta cells produce is able to work properly. So that's a pretty normal response that we saw in the lean people. That's what you want to see, a rapid boost of insulin release, and then working efficiently, as you can see, with 45 minutes starts going down in white, and then the beta cells, okay, I produce a lot of insulin, it's working, no need to release more, and then it goes down. That's a nice response. Let's look at the older group, which is in pink. Glucose levels start to rise, but as you can see, in about 15 to 30 minutes to your right, the amount of insulin being released in pink is not the same as the young people. And therefore, the levels of glucose between 45 and 60 minutes are higher than the young people. So evidently, even though these older people are lean and they are relatively healthy, you can see that those beta cells are not able to respond as robustly as the young people. Now let's look at the other group. They're also older, they're healthy, but you can see that the impaired glucose tolerance for the pre-diabetics, the glucose levels start to go up, but then as you see to your right, the right panel in green, the amount of insulin being produced in that group is very poor, very, very sluggish. Eventually, they can produce more insulin, but it's too late. The glucose values remain high throughout the glucose tolerance test. Not high enough to become diabetic. If we do this in a diabetic, it's even worse. But the point here is that in general, as we age, even in the absence of diabetes, the ability of beta cells to respond to a glucose challenge is not the same as young beta cells. And it's not clear why. It is thought that, in part, the beta cells are considered epithelial cells, meaning that they're constantly proliferating. And it is thought that the ability of the beta cells to proliferate decreases as we age. And there's also some data suggesting that some of the newer medications used to treat diabetes that I will discuss later may stimulate beta cells to regenerate, although it is debatable. So yes, indeed, as we age, their beta cells probably don't work as well, and that may be contributing to the increased risk of diabetes. And that is illustrated to your left, where a beta cell failure. But the other key issue as we age has to do with insulin sensitivity that I was referring to. And when we talk about insulin sensitivity, we can talk about it at the cellular level or the tissue level or the organ level. And often we refer to, when you hear peripheral insulin sensitivity, most cases we'll be talking about the muscle, because the muscle is the main tissue for taking up glucose in response to insulin. And as I said, that's very important, because it's taking away the glucose where it shouldn't be in excess levels, which is the blood. Now, there has been some debate whether as we age our tissues or muscle become less insulin sensitive. But in general, most people have found that yes, indeed, older people, the ability of insulin to take up glucose, of insulin to stimulate glucose uptake by muscle is reduced. Although there is still some controversy of whether this is because the actual muscle is getting old, or there are other confounding factors. For example, physical activity is a key determinant of insulin sensitivity, the ability of our muscles to take glucose, and as we age, most older people have less physical activity. Also, with aging, something that happens is called sarcopenia, which means loss of muscle mass. And as I mentioned, the muscle is this sink that picks up glucose to metabolize it. If we have less of that sink, then there's more glucose in our system. The other issue is visceral adiposity. It is thought that the adipose tissue, particularly in their abdomen, can produce substances such as inflammatory proteins and cytokines that can promote insulin resistance, and obviously as we age, there is a propensity, particularly in men, to gain adipose tissue in the abdomen. So those three factors, decreased muscle mass, low physical activity, and visceral adiposity, play a big role, an important role in the insulin resistance of aging. But the question is, what happens if you control for that? Not all older people have low physical activity. Not all of them have muscle wasting. Not all of them have abdominal adiposity. How about if you control for that? Do they still have insulin resistance? So this is data from a study we did in which we compared two groups, 26-year-olds and 62-year-olds, healthy subjects. So these are healthy, they're non-diabetic, and they were matched for physical activity. They were lean. Neither the older group nor the younger group were obese. And they had the same degree of physical activity. They were non-athletes, but their daily activity was the same. And then we measured insulin sensitivity through a test called the insulin clamp. So the data you see there is peripheral insulin sensitivity. The higher it is, it means the tissue is, the muscles are more insulin sensitive. So as you can see, the younger group with a mean age of 26-year-old clearly have better insulin sensitivity with that compared to older people, even though they were matched for other factors. So this suggests our data and data from other groups that indeed as we age, the ability of our muscle to take up glucose in response to insulin decreases. And why that happens is it's not clear. But one of the leading hypotheses is that as we age, the function and the amount of these organelles that live in our cells called mitochondria, that it declines. And just take a little bit to your biology classes. Mitochondria are these football-shaped organelles, although in reality now with more advanced microscopy techniques, it is clear that they're not isolated. The mitochondria are actually interconnected between them. But we view them as these organelles, and why are they so important? Because they take up the substrates, and the mitochondria is what makes energy, right, in the production form of ATP. So energy that we have is made by these organelles called mitochondria. So obviously, it's very important that we have normal number of mitochondria in our cells, but also that they have normal function. And in general, in studies in rodents have shown that the amount and number of mitochondria decreases as we age. So why would that lead to obesity, to insulin resistance? Well, you can imagine that this mitochondria is this organelle that is taking up the different substrates like carbohydrates and fat and other substrates to produce and to burn those substrates to produce energy if we have less of those mitochondria and they're less functional, then there is a buildup of substrates, particularly fat, inside our cells. So to see whether this was really true based on animal studies, we wanted to see whether that happens in people. So we enrolled two groups of subjects, young subjects and older. And both are NGT, meaning they're normal glucose tolerant, because we didn't want to see the confounding effect of diabetes. When someone has diabetes, then diabetes has such an overriding effect on our body that you can't really tell what's happening. So we just wanted to see the effect of aging. You can see the age there, of older group, obviously older. And their BMI 23 and 25, so they were non-obese, that's important. It's not shown there, but their daily activity was the same. Fasting glucose was normal in both, fasting insulin also, and their A1C was normal. M value is the measurement of insulin sensitivity that we do with an insulin clamp. You cannot do that in the clinic, that's just for research purposes. So the older people have lower insulin sensitivity, and also at the bottom, the O2 max, that's oxygen consumption. When you have a patient do an exercise tolerance test, you want to see the ability of that body, of that person's body, that's what the cardiologists do in pulmonary, to consume oxygen. Most of that oxygen is consumed by the mitochondria in our muscles. So obviously older people have lower, that's called VO2 max, and it's lower because there's less muscle and there's less mitochondria. So how can we measure mitochondria in the muscle? We need to go get it. So we do a needle biopsy, and obviously that's done in sterile conditions and with an anesthetic. So we go with a needle, small needle, and we take about 200 milligrams of muscle, and then we grind it and then put it in a different test tube and measure the amount of energy that the mitochondria and those muscles can produce. So the data are shown there. We have two groups, younger and older. And then the data that you're seeing there refers to energy production, ATP production, how much energy those mitochondria can make. And the mitochondria, we need to give them substrate. So it says mitochondria alone. It means that in the test tube, we don't give them any substrate. So the mitochondria cannot make much energy if you don't feed them. But then we feed them with different substrates from the Krebs cycle that are derived from glucose, such as succinate, glutamate, malate, pyruvate, right? That sounds, remember your biochemistry. Those are the nutrients that mitochondria needs to start making energy. And then the higher it is, it means there's more energy production. So as you can see, regarding now the nutrient, of the substrate we give is mitochondria, the mitochondria from older people can only make half of the amount of energy, meaning that those mitochondria are not as efficient in taking up nutrients, burning them, and producing energy. So obviously, we want to try to reverse that problem. So one way to do it is to exercise. So we had these participants do 4 months of exercise. It was supervised, and it is shown here. They were all sedentary, so we had to start them very slow. So the first week, it was just a warm-up. They would come 3 times a week for about an hour, and we would start them on a warm-up and stretching exercises because they were sedentary. We don't want to hurt them, and so they start slowly, and then by the 2nd to 3rd week, we starting at 60% of their maximal effort. I mean, there is a test in which we can find out what is the maximal effort someone can do. So we start them with 60% of their maximal, 3 days a week, and then we increase them slowly. By the end of, by 4 months, they're exercising 80% of their maximal effort. That's a high intensity exercise, 4 days a week and 45 minutes. So this improved their insulin sensitivity by about 20%, and their exercise capacity by about 30 or 40%. Their ability of their body to consume oxygen was improved significantly. So what did this do to the mitochondria? So that is shown here. So that is just data from the older group. You see the different substrates we give to the mitochondria, that's in the muscle. So before exercise is shown in white, and their response to exercise is shown kind of pinkish. So essentially exercise doubled the amount of mitochondria and also doubled their capacity to make energy. So it's essentially, by the end of the exercise period, these mitochondria from older people were making the same amount of energy as the young people were doing at baseline. So eventually rejuvenated the mitochondria to take up nutrients. And also essentially restore insulin sensitivity. So obviously this is very exciting, but we want to try to understand why that happened. So what we try to do is to identify what are the signals, the genes and the proteins that are activated when we exercise. So hopefully we can identify a molecule or a drug that can activate the same signals. And that way we can also prevent the demise of this mitochondria with aging and or improve their function. So that's one of the main things we're doing in my laboratory. Okay, so now I'm going to stop with the research and go over more practical things. I'm going to talk about some issues related to treating diabetes in the elderly, and there's no rule. Oops.
Oh, you're good. You're good.
There's no rule here, other to say that a lot of research needs to be done so we can give better recommendations. Mostly of the recommendations we have is based on discussions between agencies such as American Diabetes Association with American Geriatric Society. But so far we don't have a lot of evidence to support recommendations. So in general, we try to, and therefore they're not strict guidelines, just to provide you with information so you can make decisions. So one question, should we treat diabetes? Why do we treat diabetes in general? I'll just throw that question. Why is it important to treat diabetes? Why is it important to prevent glucose levels to be very high in our patients? Exactly. That is the most important reason to prevent long-term complications, primarily microvascular complications, right? Kidney disease, eye disease, and amputations, right? How about macrovascular complications, like heart attacks? So obviously we want to prevent them. However, normalizing glucose values have not really shown conclusively to prevent heart attacks. Of course, we want to prevent them through other means such as cholesterol, exercise, blood pressure management. So the main reason why we want to maintain glucose levels within normal range is to prevent microvascular complications. Now, if a person becomes diabetic today, how long will it take, in average, for that person to develop a microvascular complication? About 10 years in average. So I mean, some will take 5, some will take 15, right? Okay, so that's an important thing. And the reason I'm asking, if a person is elderly and it's going to take a long time to develop complications, you need to start thinking about this, right? The other key question, will everyone who has diabetes, let's assume their diabetes is not treated, will all of them develop microvascular complications?
Yes. No.
No, it's...
They got diabetes?
Yes. Someone has diabetes and they don't do anything about it. Is it guaranteed they'll get complications? No. Microvascular complications, no. Estimated between 30 to 50% will develop them. Obviously, if I have diabetes, 50% sounds like a very high risk, right? I don't want to get it. But that also means I have a 50% chance I will not. Now, I'm not saying don't treat your patients because they have about a 50% chance they won't get it. But what I'm saying this is that it's something you need to consider when you're making your decisions, okay? So should we treat the diabetes in patients who are elderly, considering that it takes years and then many of them won't? So there's not a lot of data to support this, but in general, it is recommended that yes, we do treat older patients because you have older patients with diabetes, older person without diabetes, the person with diabetes will have higher rates of premature death, functional disability, hypertension, and other rates of what is called geriatric syndromes, polypharmacy, depression, urinary incontinence. So that gives you a feeling that diabetes does confer certain problems in the elderly. Now, this figure, I'll go back to that one. So, yes, in general, we will treat diabetes in almost all our patients. Now, how tightly you're going to control their glucose, right? Because in general, the better glucose control achieved, their risk of developing complications decreases significantly, right? Particularly if the levels are close to 6.5 to 7, the risk is small versus someone who is 8, 9, or it increases proportionally. So how tight? Now, also there is no strict guideline, but you should consider before you have an older patient, actually you should consider in every patient, but particularly an older patient, the following things. One is functional status, or life expectancy, their cognitive function, and what is called clinical heterogeneity, meaning are they prone to complications or are they protected? Of course, you can't tell for sure, but sometimes you can get a sense. Let me go with life expectancy first. So this is data done here in the university and the VA. It's essentially, this is a study that assessed survival in older patients based on their frailty status, on their function. So Dr. Espinosa has studied several thousands of older patients. None of them had cancer in this particular cohort. Their mean age was about 80 years old. Okay, so they were 80, and they did a frailty test based on their strength, if they had lost weight, and whether how fast they could walk for a 6-feet walk test. So based on that, it's a very simple test to see whether a person is frail. It was categorized as someone who's not frail, who's in blue, someone who's pre-frail in red, and frail, that is in green. These are not patients in the hospital who are dying. These are ambulatory people. And based on that, they followed these patients for about 13 years. I still don't know why Dr. Espinosa put that in days and not in weeks or years to make our life easier. But 5,000 days, how many years is that, Mark? 13?
Bring my calculator.
And so the top, when it starts to mean that all of those patients are alive. So they were followed every year to see how many were alive. So as you can see, people that started being frail, they were dying faster. They were, compared to the other two groups. The ones in red, they were, the rates of survival were in between. And obviously, if someone starts frail, and there's no intervention, this is just a test. If you're frail now, your risk of dying will be higher compared to someone who's not frail. But the issue I want to show you this, if you have an 80-year-old, remember these people were 80 years old, and they have good function. They're not frail. By about 13 years, the majority of them, 75%, are still alive. So when you have an older person and you try to estimate their life expectancy, of course this is very difficult, but that is an important consideration. If you have someone who is 7 years old and they're healthy, they have still a good chance they will live another 10 to 15 years. So that might affect your decision of how aggressive to treat them, right? Functional status, that's something that I mentioned. Cognitive function. In general, since aggressive, tight glucose control requires a fair amount of effort, repeated blood sampling, frequent insulin dosing in many cases, or many medications. And the backdrop that there is no strong evidence suggesting that in older people will benefit. In general, it is advised people with poor cognitive function, some with advanced Alzheimer's disease, the requirement to treat them aggressively, or the need to treat them aggressively is not very strong. So so that might be someone who you may not be as may not feel so strong about being aggressive. The other issue is clinical heterogeneity. So this is also a tricky one because we don't want to be guessing with our patients. But if a patient has had diabetes for 50 years and they have not taken good care of them, of their diabetes, and you see them at age 75 and they have beautiful retinas, no kidney disease, beautiful feet, and they have an A1C of 8 or 8.5, are you going to start treating them with insulin and metformin? And no, we need to get you to 6. Say, doc, I've been doing fine for 50 years, And then, so all those things are that you should consider: functional status, life expectancy, cognitive functional, clinical heterogeneity. So, in general, these are no rules, not rules. If a person it's functional, has good cognition, significant life expectancy, the goal is to treatment as if they were young, with an A1C more or less of 7 to 7.5. And again, there are no rules. That is just a general recommendation. But someone with decreased function and cognition and short life expectancy, the glycemic control can be relaxed. Maybe an A1C of 8 or 8.5 is more reasonable. But certainly you don't want to avoid hyperglycemic complications. Don't leave your patients around or walking around with an glucose of 300, 350, or 400 because they might go in the hospital with an infection or dehydrated or even diabetic ketoacidosis, even they're type 2 diabetics. So it's probably, in terms of glucose levels, probably these patients between 100 to 200 and an A1C of about 8 to 8.5. Again, these are not rules, but it's a general recommendation. And it's certainly for debate. Now, I'm going to go over some issues related to drugs. I'm not going to discuss insulin use in the elderly because that's a whole different topic. But I'll just talk about some medications and choices. I'm going to start with the sulfonylurea. So sulfonylureas are drugs that work by making the beta cell release insulin. They don't stimulate production of insulin, but those beta cells have insulin stored. The beta cells are constantly making insulin. The beta cells have a specific receptor on the surface, and these drugs bind to the receptor and make prompt the beta cells to release all the insulin they have inside of them in a dysregulated manner. So the good thing about sulfonylureas are very cheap. They're actually quite potent. There's no oral agent that is more potent than sulfonylureas. They can lower A1C up to 2%. But there are obviously problems. One is weight gain. The other is hypoglycemia, which we see a fair amount of it. And the other, but the consideration with aging is that their half-life gets prolonged, and therefore their risk of developing hypoglycemia in the elderly is even higher than in the middle-aged and younger people. So the half-lives of the different drugs of sulfonylureas are shown there. Chlorpropamide is, I don't even think it's available anymore. The ones that are more used in the US are glipizide and glycolide. And so those half-lives are for young people. So for elderly, they're probably 50% to threefold longer. So the longer a half-life, the risk of hypoglycemia even worse. So if you're going to give a sulfonylurea to an older person, use glipizide, which has the shortest half-life. And probably just start with very low doses and use it only once a day. Okay? Typically it's given twice a day, but in elderly it's recommended to be once a day, and there's no need to use other drugs with longer half-lives. Okay, metformin. Metformin is the drug of choice in cases of type 2 diabetes because it not only is as efficient as any other drug, it's also very cheap, but more importantly has protective effects against cardiovascular disease. It's the only drug that probably unequivocally has been shown to decrease cardiovascular rates and even might prevent other diseases such as cancer. Something good about metformin in some cases, but not in all, is that they can cause weight loss. So if you have an older person who's malnourished, you may not want to give them metformin if it's going to decrease their appetite. So that's another thing to consider. No hypoglycemia, so that's a good thing. Now, the key thing with the elderly is that one, be careful with appetite. It can be suppressor appetite, and as I mentioned, older patients are not always overweight. Often they are thin or even malnourished. So you don't want to suppress their appetite. The other issue is renal function. So lactic acidosis is a very rare side effect with metformin, but it's warning in the box. Therefore, we do need to be aware of it. Most cases, even though have been very rare, most cases of lactic acidosis with metformin have occurred in patients who have very poor kidney functions. That's why you don't give it in patients with impaired renal function. So typically, the recommendation is metformin you don't give to a woman with a creatinine of 1.4 or higher and to a man with 1.5 or higher, right? Because you don't give metformin to someone with abnormal kidney function, so how do you assess kidney function? You measure creatinine. But there's a but in older patients. And in older patients, the issue is, remember I mentioned that there's loss of muscle mass in the elderly. So the creatinine that we measured in the plasma, where does it come from? It's a substance that comes from creatine that it's coming mainly from the muscle. So if someone has small muscles, their creatinine levels will be low. So it's not unusual that you have an older patient has the typical thin older patient that has normal kidney function, their creatinine will be 0.4, 0.5, which is not abnormally low, but it's low because their amount of muscle mass is lower compared to the other person. So if you have an older person who's lean, has small muscle, and the kidney function is their creatinine is 0.4, and then it goes to 1 or 1.5. Well, that kidney function is getting worse. It doesn't mean that the muscle mass is increasing in that person. It's that the ability of the kidney to eliminate the creatinine is impaired. So the bottom line is that plasma creatinine levels is not an accurate measure of kidney function in the elderly. So in people that are 80 or above, you can use metformin. However, you don't make your assessment of kidney function based on plasma creatinine, but a creatinine clearance. And if the creatinine clearance is less than 60 mLs per kilogram per minute, then which is the normal is typically over 90, and those patients don't use it. So it can be used, but just be careful in over 80. TCEs, pioglitazone, rosiglitazone, those work mainly in the liver and the muscle. They improve insulin sensitivity. There's a lot of bad press, particularly against rosiglitazone, because there were some information suggesting that it might increase cardiovascular disease. I think in general, nowadays, looking back, most meta-analysis do not conclusively shown that either pioglitazone or rosiglitazone increase cardiovascular disease. In the case of pioglitazone, it actually may improve it slightly, and maybe. There's no really, in my mind, no reason to use rosiglitazone versus pioglitazone, because rosiglitazone almost unequivocally will increase LDL level, and you don't want that to your patient. There's also some information that it may increase the risk, these drugs increase the risk of bladder cancer, although in general I think that has been disproven. But certainly someone with a history of bladder cancer or hematuria shouldn't be used. Lastly, there's also some data, and I think that seems to be holding up. They do decrease bone density, although there's no data indicating that they cause fractures. But certainly you don't want to use it in someone with osteoporosis. Sometimes we like to use it because they are as efficient as metformin, but they cause weight gain. Certainly weight gain is a problem in someone who's overweight, but it won't be much of a problem in your malnourished patient, right? So that's something to think about when trying to find a choice. It doesn't cause hypoglycemia. It very rarely causes hypoglycemia, and both metformin and TCDs are as efficient in older patients are in younger patients. There are some suggestions that the preventative effect of metformin on diabetes may be more efficient in young people, but it's unclear. These medicines don't use, in anyone who has edema, more than trace edema, anything more than trace edema, congestive heart failure, liver function, absolutely don't get anywhere near. Someone with osteoporosis, don't use them. I do sometimes use it, as I mentioned, in older patients who I'm not that concerned about weight gain. The other class of drugs are drugs that work through the incretin system. Incretins are hormones made by the gut, and there are many of them. One of them is called GLP-1, and this hormone that is made by the gut has many effects that are potentially beneficial. For example, it suppresses appetite, something that is desirable in many patients with type 2 diabetes. It also increases insulin levels and delays gastric emptying, so that prevents rapid rises in glucose. So when this was discovered, drugs that worked such as like GLP-1 were developed, and the typical ones is exenatide or Byetta, and there are many others now that can be used once a day, twice a day, or even once a week. As I'll mention, they are efficient. The problem is that they can suppress appetite, and as I mentioned, just you want to be careful in your older patient who may be malnourished. The other family of drugs, it works by inhibiting the enzyme that breaks GLP-1. So GLP-1, which is a natural hormone, is broken down by this enzyme called DPP-4. So there are drugs that work by inhibiting this enzyme. Therefore, the amount of DPP-4 in our blood is higher. And those are shown there. The ones that work at GLP-1, exenatide and liraglutide, they don't cause hypoglycemia, but they can cause nausea. It's actually fairly frequent, about 1/3. It works in older patients, and there's some suggestion that it might regenerate beta cells, which is a problem in older patients, but that needs still to be proven. The other drugs that are inhibit the enzyme DPP-4, they're called DPP-4 inhibitors. They're taken orally. some shown there, sitagliptin, saxagliptin, linagliptin. Their benefit is that they can give it orally, and they're very well tolerated. The problem is that they're not very potent. Maybe they decrease A1C by about 0.5%, although a combination with metformin and DPP-4 inhibitors can be quite useful, particularly in patients with mild diabetes. So I'm done? 2 minutes? Okay, so I have 3 cases. I think that I will show this one. So these were real cases. 75-year-old man with type 2 diabetes since mid-50s, almost never saw a drug. He used glipizide and insulin, but nothing recently. He drives a truck through San Antonio, distributes produce. He has hypertension. He takes hydrochlorothiazide on and off. He's obese. Blood pressure is not too bad. No retinopathy, no neuropathy, little swelling in both legs. Creatinine 1, urine albumin creatinine ratio 25. The abnormal is over 30, so there's not spilling protein. A1C is 9.7. So are we going to treat him? Glucose is 289, or we just going to goodbye? Probably going to treat him, right? As I mentioned, we don't want our patients to be walking around very high glucose levels. What is the A1C target in this patient who's been doing quite well? Are we going to bring him from 9.7 to 7 very fast? No. Probably not, right? Would you give him insulin? He's driving a truck. No. And he's not very compliant. Sulfonylurea? Probably not. So what would you give him? Metformin is the ideal drug for him, and hopefully we can bring down his A1C to about 8. And maybe with some of the other agents, we can even try to push him down even further. But I think certainly recommending the ideal is also weight loss and physical activity. And metformin, I think we can get him close to an 8 with that. And I'm going to break my rule and just skip to the last one, because it also illustrates what I'm trying to message here. 68-year-old woman with diagnosed only 1 year ago. She was brought to my clinic by her daughter. The patient has end-stage pulmonary fibrosis, unknown etiology, and home oxygen therapy. She takes Glargine, 50 units at bedtime, and Lispro, TID. The daughter, who's a wonderful woman, is very, very caring. She checks her glucose 3 or 4 times a day, and counts her carbs very strictly, so her glucose levels don't go up very much. So in physical, her BMI is 23, and her O2 sat with oxygen 89%. No evidence of microvascular disease. So creatinine is normal, no urine albumin is normal, A1C is 6.1 because the daughter is doing a very good job. Glucose 92. So I spoke with the daughter, the lady, asked her, what she enjoys in life, and obviously she likes to be with her family. She also likes to cooking and eating, but she hasn't been able to do much of that because of her diabetes. So what would be the ideal target? Would you leave her on that regimen? So what is her prognosis? End-stage pulmonary fibrosis. Not good. Probably die within a year, right? Yeah. So
leave her alone.
Leave her alone. Yeah. So essentially, what I did is just no more insulin. Just check her glucose maybe once a day or every 2 days, and if it gets over 250, to call me. So so this illustrates this fact that it's important to consider the life expectancy of the patient. Essential at the end of the day, the decision is made by the patient, the family, in this case, but and also by the healthcare provider. Just to consider that you're treating a patient and not a number, and that sometimes by trying to treat a number, you're harming the patient. So I think I'm going to end there, and I'm sorry that I went a little long.
Okay.
I'm gonna-
Thank you. Appreciate it.
Swingy Harlem tunes, motor trips and burning lips and burning toast and prunes.
How lovely it was. Thanks for the memory.